Good morning, everybody, and welcome to the latest in our How To webinar series. My name is Katie Legg, and I'm the Director of Strategy and Partnerships at Mental Health UK. Mental Health UK is one of the UK's leading charities when it comes to workplace mental health. Now, today's a really exciting session. I've been looking forward to this one for some time. Today, we're going to be talking about how to support colleagues through and after negative life events. And I'm absolutely delighted to say that this morning I'm going to be joined by my colleague Liam Southam, who is joining us from Rethink Mental Illness. Morning to you, Liam. How are you doing?
I'm really good, thank you. How are you?
Yeah, not too bad, thank you. Thank you so much for coming and joining us for today's session. I think it's going to be a really good one. Now, just before we kick off into some of the discussion today, I just want to let everybody know that we are recording today's session. So if there's anything in particular that catches your eye, you'll be able to watch that back a little bit later on. We'll be sending it round to all of you on email, along with any of the other tools and resources that we talk about as we go through today's session. There will be the opportunity for you to ask Liam lots of questions as we get to the second half of today's session. So there are a couple of chat functions available to you on Zoom. So please do make both the best use of those, and we'll make sure that we get to them a little bit later on today. But let's get cracking, shall we, Liam? First off, why don't you just tell us a little bit about what it is that you do at Rethink Mental Illness?
Yeah, so I've been with Rethink about 6 years now and started off in the criminal justice contract, so providing talking therapies to those in prison. So my core training is around low intensity cognitive behavioural therapy and so CBT and interpersonal psychotherapy or IPT. And then I've moved over in the last year to kind of supporting in the care navigation service. So we're supporting people with mental health and health vulnerabilities who are coming out of prison. So trying to kind of improve health outcomes and get them engaging with mental health services and just get them kind of the best support possible in the community, and because it can be a scary time for them coming out through the gate. But yeah, that
sounds fantastic. Sounds really interesting. And with today's session, we're going to be talking about negative life events and how to support colleagues through and after those. And it's probably worthwhile setting the scene before we get going with that. What do we mean when we talk about negative life events?
I think it can vary based on the individual, can't it? Like, I think dependent on your own kind of circumstances, but you know, I suppose in my career, I've come across lots of different negative life events. So people who I've worked with are facing kind of serious illness or have experienced kind of abuse in the past, or it could even be like moving home or financial difficulties. I think it's I know a massive spectrum, isn't it? Like there's just, it's really individual to the person, and I think people just cope with things in different ways. But yeah, I think it can be really severe or kind of a more mild event that people are struggling to manage.
And I guess with some of the examples that you're talking about there, that's just as relevant for anybody in the workplace as it is for some of the environments that you've worked in before.
Yeah, definitely. I think in the workplace, I know, like, I suppose in my role now, we like do a lot of supervision. And it could be like people having difficulties at home in their family lives as well, or struggling with their current kind of duties and role within work. But yeah, I think that, and particularly through the pandemic, I think it's been really hard for people with the changes at work and like kind of being stuck at home and stuff as well. There's just been lots and lots of challenges, hasn't there, over the past kind of, well, what we're coming into like 18 months now. It's been a long time, hasn't it?
Yeah, absolutely, and plenty of opportunity for people to have experienced some of the things that we're going to be talking about today. And so taking forward some of these examples, if a person discloses to us in the workplace that they are experiencing a negative life event, or they've experienced a negative life event recently, even if they haven't disclosed that to us, what are the sort of the signs and the symptoms that we might see in that individual?
Yeah, I think signs that they might just seem just not quite themselves, so they might seem a little bit more slowed down or even more agitated than they normally would. They could be talking about things that they're doing less than they normally would, or just seeming just more anxious or unhappy. they might not be as engaging in supervisions, or I suppose, I think it really varies. There's just lots of different things you could notice, but they could be having difficulties in their relationships at work or relationships at home. But definitely, I think if you're looking for kind of more physical, like observations that you might notice, is that, that kind of more slowed down or irritable, but or just seeming quite deflated, I suppose.
So it could be quite difficult to spot without knowing some of that information about the individual.
Yeah, I suppose if you know them well, then you're going to notice it a lot easier, aren't you? Because you'll kind of see that someone's not quite themselves. But I suppose if someone does disclose it to you, just listening to what they've got to say and normalizing it, like validating what they're saying as well. And I think avoid trying to like self-diagnose or using Google and things to kind of work out what's wrong, and just maybe trying to point people in the right direction of the support that's the most available, like the best thing that's going to be available to them to support them. But
and so with that all in mind, somebody tells you about this life event that they've been through. Does that warrant a diagnosis?
I mean, the diagnosis is really difficult. I think that, and a lot of psychological services now kind of try and steer away from a formal diagnosis because it's not always helpful. I think some people can fixate on the label itself, and really and definitely with the work that I would do with somebody is we would focus on the kind of the symptomatic distress that they've got in the here and now. So you're not discrediting what people have been through at all, because obviously there's a trigger in there somewhere that's caused them to feel this way. But actually putting a label on that isn't helpful for everybody. And particularly I think with the diagnostic criteria that we would use, like all healthcare professionals would use, certain diagnoses require like a really severe set of symptoms. And I think just what I would kind of get people to focus on is what the current issue is, what people are really struggling with here and now, and how can we best manage that. So, does the emotion kind of fit the facts that they're having? So they've been through something really difficult. How are they feeling from that? And what do they need to do to improve how they're feeling? So is it kind of utilizing their support networks and people that they've got around them, or do they need to kind of some guidance into some talking therapies or seeing their GP? Because there are so many different treatments out there that people can kind of access now. But I think just having a negative life event wouldn't necessarily warrant a diagnosis. There's multiple different diagnoses that it could be as well, but I think, so no, really, to answer the question, it wouldn't.
Yeah. That's really interesting, because I think, there's been so much focus that's been placed on individuals' mental health as we've gone through the pandemic. And I think, I'm sure you'd say the same working in a charity. Actually, it's really positive to hear mental health talked about so widely, so openly. And, maybe for the first time, we're really sort of understanding how it's equally as important to an individual as their physical health. So seeing that conversation sort of really accelerate in the public eye, personally, I feel that that's a real sort of positive for us. Quite interestingly, one of the pieces of rhetoric I've heard a few times over the past couple of weeks and months has been a growing conversation around post-traumatic stress disorder and sort of the prevalence and the likelihood of people experiencing that and being diagnosed with that as we've gone through the pandemic. And it's quite an interesting one, isn't it? Because it's often so widely associated with the armed forces, but now we're hearing about it a bit more and we're talking about it a bit more. I wondered if perhaps you could talk to us a little bit more about PTSD and what it is, what it requires to get a diagnosis for that condition.
I mean, PTSD is a very kind of common mental health problem, and again, it's very treatable. I think now, like nearly all mental health difficulties now and mental illnesses are treatable. So I think if somebody was to be diagnosed, whether it be yourself or a friend or colleague, that actually you can instill that hope with people that this is treatable. There is options out there to kind of help you to manage this. I think from my experience of PTSD that to get a diagnosis, it's always a really severe set of symptoms. And I think when they're looking at the life events, it is kind of more when you're thinking about what like veterans and things would experience. So it looks at like kind of war and conflict and torture, physical, sexual abuse, kind of near-death experiences, or like witnessing the death of a loved one as well. Like they're kind of, if you're looking, so the DSM-5 is like a diagnostic manual that healthcare professionals would use. It's kind of, that would be the criteria that you would be looking for, like the event that you would be looking for. And then the symptoms from that, you're looking at kind of recurring flashbacks and nightmares. But again, it takes a really long time because they have to assess that these aren't just thoughts that you're having and memories that you're having of the kind of the event itself, but the impact that that's having on you, where there can be lots of dissociation. So where people feel like they're just not in the room anymore and they kind of get lost in the flashback. Again, there's lots of differential diagnoses from that, like I was saying before. So there could be like symptoms of depression and anxiety, panic attacks, people, I suppose, being more hypervigilant to their surroundings and just seeming kind of more on edge. There's just you'll be looking at somebody that might be isolating as well. So someone that's kind of withdrawn from colleagues, friends, family. There might be an increase in really unhelpful behaviors as well, such as like drug use, alcohol misuse and things as well. So yeah, then like impacts on self-esteem. There's the I think as well, and from looking at like NICE guidelines and the DSM criteria, it's such a long list of symptoms that you have to meet. And I think that within the services I've worked in the multidisciplinary teams, I know that psychiatry are more kind of keen on diagnosis, but definitely within the psychological model as opposed to the medical, you're looking more at symptomatic distress and treatment as opposed to diagnosis. And even with the psychiatrists we work alongside now, they often diagnose traits of something. So it might be traits of PTSD or traits of depression or like personality disorders, that kind of thing, because the diagnosis for PTSD, I think, takes a really long time and a long like period of assessment. Which is why, again, with the people that I would work with my kind of clients, that I would focus on symptoms and treatment. And you know, there is therapies out there that you can access where you can spend more time talking about the event itself, but for lots of people, they don't want to, and it can be quite dangerous as well because of the potential of like re-traumatizing people. But yeah, I think the diagnosis of PTSD is a big process, and I think if somebody is really struggling with that, so if they are feeling quite anxious, quite depressed, struggling with flashbacks, nightmares, that kind of thing, it can be hard, because when's the individual going to be in a really good place to kind of sit to be able to process and discuss all of these really difficult things.
Interesting to talking about the length of the process there. We've just had a comment in from Verity. Morning to you, Verity, and thank you for sharing your story. She said she's an ex-head teacher who has had to give up her career due to PTSD, and it took her 18 months to get treatment. So I guess that's just a classic case of exactly what you're talking about there. And it's a long time to not get support, right? It's as you say, it's really important to focus on what's happening in the here and now.
Yeah, absolutely. I think as well, because you can work with multiple different professionals, whether it be healthcare, mental health, and you know, we've got the diagnostic criteria, we have NICE guidelines that we follow, but people also have their own views and training on things, and that can vary too. I mean, the services I've always worked in have been like IAPT services, so kind of the focus is around improving access, and a lot of the therapies all of the therapies, actually, thinking about it, that I've had training focus on the here and now. So you cannot avoid thinking about the trigger. Like it's really important to discuss it as well, because we formulate, so you want to understand the bigger picture for everybody. You want to know what's happened that's led up to this point. But really what I think is so important is like the impact that this is having on you now and how we can improve that, because you want people to kind of be as well as they can be. You want people to be functioning at like full capacity, basically, so that they are getting on well with friends, family, kind of enjoying their lives is what I think is so important.
Absolutely. And so let's run with that then. You know, we're talking about today about how colleagues can support each other, whether they're, you know, peers, whether they're the employees, etc. So the colleague has sort of disclosed this information with you, or you're spotting the signs and you're spotting the symptoms. As a peer, as a line manager, what should you do?
I think, listen to them, like definitely listen to people and offer validation that, that it sounds like you've been through a really difficult time, like, but look at the options moving forward. I would avoid questioning about it, like you don't want to dig too far into the event itself to potentially re-traumatize somebody, but kind of offer, and again, avoid kind of suggesting diagnoses as well, or like comparing to other people, like it is their individual experience, so just keep it about them. So like that was really hard for you, that sounds like you're going through a really difficult time. Ask them what they might need, like what support do you think that you need right now? Think about the employee support that can be in place for people. I know that we've got through Bupa that we would use, like so any kind of systems that you've got like that. If you know of any local services that you could refer people into, or encourage, not necessarily you referring to, but maybe encourage people, make a self-referral to, because it is really easy to access support now in the community, but signpost people to their GP. But I suppose it's what you're comfortable with as well, isn't it? Like if someone's talking about a really difficult life event, that could be really uncomfortable for you, and you might have your own feelings about something very similar, so you have to look after yourself as well. It's really important for self-care too. But yeah, I suppose just empathize. It's all you can do.
Absolutely, and I think there's some fantastic questions coming in, by the way, which I'm going to come back to in a moment. But they sort of lean on some of these things that we're talking about here. But I guess there's a couple of real, important things that you've just sort of said there. One is that point of self-empowerment. An individual might be talking to you and know what they need, they know what they want, they just need to have that conversation, and they feel that you're a trusted person that they want to have that with. I think that the second thing that's always important when we have these conversations and do these webinars is to remind people that I'm sure there are some psychotherapists and some psychologists who are on the call today, but for the majority, that we're not trained in this, and actually it's not our responsibility to actually respond to the individual. You started to talk there a little bit about sort of GPs and other services that people can access. Can you tell us a little bit more about those and the practicals? What do you do?
Yeah, I mean, obviously with the GP, you just make like your standard appointment, but I know to get access to IAP services, you could go onto Google. There's and just look for local IAP, local talking therapies. Often you'll put some information in on the homepage, and then somebody will give you a call relatively soon and invite you either for a telephone assessment or a face-to-face assessment. Talking therapy services, IAP services are ready for an influx of referrals at the moment. There's been like lots of CPD events going on recently around kind of the impact of the pandemic and just I think people preparing for an increase in distress, I suppose, at the moment. There's also on the NHS website, there's a useful resource where you put your postcode in and it'll tell you where the local services are in your area. But again, you can discuss, if you have an appointment with your GP, you can discuss all of this with them. But you can self-refer. So if you don't want to go through your GP, you can make a self-referral and go through that way. But obviously the GPs will be as supportive as they can be and pointing you in the right direction.
Yeah. Okay.
Yeah.
Right. And so you are both a qualified psychological wellbeing practitioner delivering low intensity CBT and an interpersonal psychotherapy practitioner. So, I mean, that's a lot of words for starters. I'm it all out. And they sound absolutely fantastic qualifications to have. What does the help that you give in either of these roles look like to a person who we might be talking about today?
Yeah. Well, within CBT, so what with the low intensity CBT and with IPT as well, you look to formulate with your service user, with the client in the beginning. So what you want to do is build a picture of what's been going on for them. Within CBT, you would look at what the trigger was, so what's kind of causing the difficulties at the moment, and then you look at the implications that has on a person's thoughts, feelings, and behaviours. And then within the work that you would do, the treatment that you would offer, you would look at breaking the negative cycle that they could be caught on, whether they're thinking really negatively because of something that's happened to them. So you might do some work around thoughts and hopefully that and the knock-on effect that could have with the kind of the feelings and the behaviors. Or you might look at the behaviors if people are isolating or just not taking part in the activities that they once would have done. Like, you might encourage people to be more active and try and improve their mental health that way. CBT is not super invasive either. Like, it's very practical. So you're looking at lots of different coping skills that will help you manage, again, in the here and now. You're very present focused in the therapy. IPT is a little bit different. And interestingly as well, in IPT, so it's got 4 focus areas in IPT. So you're looking at kind of complex grief, role transitions, which can be difficult life events, any kind of significant life events that cause distress, any kind of conflict, and any kind of interpersonal sensitivities. But within the work that you would do after your formulation on like role transitions, like negative life events, you would spend time processing that with somebody. So you would talk to them about the event itself and how did that make them feel? How does it make them feel talking about it today? And try and help them process that emotion. If it's been like a really big change in things as well, you might look at positives in the now and kind of in the here and now, and try and find like positivity within that. But also throughout all of the treatment, you're looking at people kind of engaging in lots of activities that they were doing before. So trying to kind of spend lots of time with friends and family, and like access their support network, and if they're interested in doing new things, trying to encourage them to do that. But yeah, it's like lots of exploration and kind of just again, but thinking about the emotion that the person's feeling. So you're thinking about what triggered this current episode, and how is that making you feel now, and how can we make you feel better moving forward? And you would review that week on week. But yeah, that's kind of.
I have to say, I'm really enjoying talking this morning. It's really enlightening and just insightful to listen to how some of these processes work. It's not something we get a lot of access to sometimes, because it depends on whether people want to talk about it. And I certainly feel sort of very inspired listening to what you do. You must be really proud of the work that you do as well.
Yeah, I love it. I do. I think like every day is different, and it's really nice to see people through their kind of like recovery journey. Yeah. And people can seem really defeated in the beginning, and there's that lack of hope. And I think that one of the things within therapy is you really want people to feel like the expert in their own journey. And we put a lot of things back onto the client as well. So if they're asking for like, what do you think I should do? Like, it is always put back, what do you think that you should do in this situation? Because you want people to feel empowered and kind of in control of what it is that they're feeling. Because I think one of the big things with any kind of negative life event or any kind of like emotional distress is people feel out of control, don't they? And things can feel really turbulent, and what people are trying to do often is kind of grasp onto things and kind of feel a bit lost with it. So I think, yeah, it can be really helpful to sit down with someone neutral and just kind of piece it back together.
Absolutely. Now I'm seeing on my screen here that we've got a lot of questions coming through to us. So what I'm going to do is move us on to those in a minute, and we're going to see if we can answer as many of those as we possibly can in the time that we've got this morning. But before we move on to that, one of the things, Liam, that we really try to do with these webinar sessions is make them really practical, so that people can walk out of these sessions today, and if they know of a colleague that's expressing some of the behaviours and the signs that we've talked about, that they have the tools that they need to go and support them immediately. What do you think we can send on to the audience a little bit later on today by means of signposting, referral tools that they can be using?
So I know that, like what I said before, there's the NHS link that you can put the postcode in, and it'll bring up lots of local services in your area. Right. Again, just having a look online at local talking therapies or local IAPT. IAPT is huge now, and it is all about improving access. So people do ordinarily get into the service relatively quick. And I think even then you can get that sense of hope because you know that treatment is coming. I know, so because I'm based in the Northeast, I know we use our local NHS trust has self-help guides online, but I mean anyone can access them. So the NHS self-help guides are really, really useful tools, and we actually use them a lot within sessions. But they do have a step-by-step guide of you kind of formulate for yourself, and it can be a useful resource to use prior to engaging in talking therapies, or you might not even need it after you've used it, because it can be really helpful. But there's like a whole range of different difficulties that people have on the website, on their the guides that they've got. So that's definitely a useful resource that you can access. And I know Rethink Mental Illness have on their website as well, kind of information about different treatments that are available, and lots of information about different mental illnesses and mental health difficulties that people might have. So lots and lots of signposting information, because I think a massive part of the work that we do is around psychoeducation and just helping people to understand the difficulties that they're having, because I think it makes people feel less isolated and alone with it as well, and it normalizes it for people, which is so important as well. So that, because I think a lot of the time people feel like difficulties can seem really sinister, and actually it could be something that a lot of the time it's something that's very common and very treatable, and that kind of helps people to understand that. But yeah, so that's I suppose that all those things that we could send on, definitely.
That sounds great. We'll definitely make sure that we pop that out to everybody a bit later on today with the recording of this. So if anybody wants to listen back, they're very welcome to do so. So lots of questions here for you now. Let's see if we can get through some of these. It's really interesting. The first two questions I've picked out are almost at the opposite ends of the spectrum to each other. So the first question is, what advice would you give if the person struggling is unable to locate anything that triggers their negative feelings?
I think you don't always have to understand the trigger, like as long as you can understand the feelings that you've got now. So if the person is able to identify what it is that they're struggling with, so they can identify the different emotions, and you would look at like a day, I suppose, a normal day for somebody, and how they feel first thing in the morning, the afternoon, the evening, what emotions they're feeling, what different thoughts they might be experiencing, and then you can form a treatment on that. But again, I suppose, like in that situation, I suppose it depends on your background, but you might want to signpost into talking therapies or to the GP, or get people to, one of the things that we do a lot in sessions as well is get people to write things down, because a lot of the time it's helpful for them to get it onto paper so that it's not just rolling around in the head. And sometimes you can just reflect on those things as well then, and that can be really helpful for people, because you can it might be a certain time of day that you notice more things, and the trigger isn't always important within the sessions, it's the impact that you're looking at.
Absolutely. And presumably we would encourage as much as possible for that activity, to be conducted by the professionals. But if an individual wants to talk about it, then of course that's a safe, that's a reasonably safe space.
And I suppose just offering that reassurance that it's okay if you can't, like some people can't, like one of the things in IPT as well that we would do, because some people don't understand what triggered how they feel, is we create a timeline. Again, I would encourage you to do that with a mental health professional, but you would do a timeline with somebody and looking back over kind of how they feel today, and then going back of when they felt a little bit better to find out what the key trigger was. But it isn't always obvious for people, and it's not always necessary to know either. You can still treat the impact, you can still treat the current presenting problem without knowing what's caused it.
Okay, that's really helpful. And so conversely, we've got another question here that says, when a colleague insists on talking about the past and triggers, how do you bring them back to the here and now?
Yeah, that's a hard one, isn't it? I think if you're talking to one of your colleagues, because you don't want to seem like you're kind of discrediting what they're saying, do you, or kind of just trying to move away from it. But I suppose in that situation, you could kind of acknowledge what they're saying. Like, that sounds like it was really hard for you then, but how are you feeling now? Like, what kind of impact do you think it's having on you, like now? Like, where do you think there's going to be the best place to get support, or what do you think you need now? Like, to kind of, one of the things within DBT that you'd look at is kind of a radical acceptance of, like, you can't change the past. It is what it is. And I know that sounds really easy to say, and it's very different for the person in the situation, but it's like, sitting in the kind of the distress that caused this issue isn't going to change it, but actually let's look at how you feel now, and how can we help you moving forward? What's going to make you feel better, or what do you think might make you feel better? And maybe have some, the self-help guides can be really useful for that as well. Mindfulness can be really useful in those situations, although I suppose I would get people to research that a little bit as well. But yeah, it's a tough one, I think, when it's a colleague, isn't it?
So lots of open-ended questions.
But I think a lot, and again, like kind of bringing them back to the here and now. So acknowledge that what they've said sounds hard, but how are you feeling today? Like, how's this week been? Like what's the plans moving forward? Like, just always try to kind of pull it back. So we're thinking about like just the current kind of symptoms, the current impact that it's having.
Okay. The next question is about self-harm. And the question is, if a colleague discloses to me a negative life event and I'm worried they're at risk of self-harming, should I disclose to my employer or should I keep it confidential?
That's a tough one. I think if we're working with somebody, we'd do like a very thorough risk assessment. So you're looking at somebody's thoughts and their plans and intent to act on those thoughts. If your colleague has spoken about this quite openly and wanting to harm themselves, then I probably would. We would break confidentiality with the service user if we thought they were going to hurt themselves or hurt somebody else, or if there was a lot of suicidal ideation there as well. So it would really depend on kind of what was being discussed in those conversations, but yeah, or kind of signpost to crisis resources as well. So there's like, you've got the Samaritans that you can access. There's a crisis text line as well that we could share with everybody, because I know some people don't like to talk about it, but the texting can make it kind of feel just a bit more distant and more kind of anonymous. But yeah, there's in your area you'll have a local crisis team that you could kind of direct to, but dependent on kind of what is being the level of the risk would be whether or not I would discuss it with a manager.
Yeah, that duty of care is
there
for all of us, isn't it? And it's not just about us as individuals, as an organisation, as a corporate. We do have that responsibility for the people in our trust.
So and be open with them. Be open with the person that you're talking to and just say, I'm worried about you. I'm really worried about the things that we've talked about. And because of what you've said, I am going to talk about it with somebody, but it's because I want you to have the most support that you can get. I want you to be safe. It's not a punishment, is it? And I know that sometimes people can feel hurt by that, and there can sometimes be a little bit of negativity towards you because of it. But ultimately, you're wanting to keep them safe, and hopefully they'll see that.
Yeah, great. No, completely agree with you there. The next question is from Aidan. Aidan asks, can you experience long delayed PTSD, for example, severe bullying in school impacting on an individual a long time later on in life based on their experiences in work?
Yeah. I know that within PTSD as well, it doesn't always develop at the time of the event. It can be like, I think a more complex PTSD would kind of occur later in life. But potentially it could be that the event that you're experiencing or the person is experiencing now has triggered what you experienced as a child. So it might not be that it's a delayed kind of PTSD and kind of trauma impact, but that you have been triggered by an emotional response because of the experiences being very similar, which is often the case with PTSD with trauma, is that there'll be certain sounds or smells or words, I suppose, that'll cause a trigger and an emotional response.
Okay.
Does that answer the question? Sorry, I don't.
I think so. I think it's sort of given this sort of light of it's entirely possible, but again, it would come back to seeking the support of the professionals, wouldn't it? So and making sure that you're taking that on there. Another really interesting colleague here, and I guess this one is all around disclosure as much as anything else, but if a colleague has been signed off because of PTSD, should we be talking about it as a team at work? Do you think that that's something, let's assume in this instance that the person's diagnosis has been shared across the team and it's not a breach of confidentiality. Do you think it's important for peers in the workplace to know and understand more about it?
I don't know. I think in some situations, I suppose, yeah, like if it was a management team, and I think it would be really important for everybody to be understanding of what support needs this person had. But I suppose that an entire team wouldn't need to know the ins and outs of somebody's difficulties, because actually that could be really exposing for the person. And not everybody wants everybody to know what's been difficult for them. I would discuss that with the individual themselves and find out what they wanted to know, like what they wanted their colleagues to know or the teams to know, about kind of looking at their support needs and whether or not they're a close team, and maybe they would appreciate having everybody kind of in their support team. But yeah, I think that would again be definitely on like an individual basis, because some people I don't think would appreciate it, some people might.
And at Mental Health UK, we do a lot of workplace mental health training, most of which starts with sort of the general understanding and awareness of what mental health is and what mental ill health is, and then also around sort of championing positive cultures in the workplace. And I would think that, if the individual is not prepared to share, or that's not something, actually just developing that, underlying current of positivity and understanding around mental health is probably something that's quite important.
Yeah. But it could even be that, everyone, I mean, people naturally, when somebody's not at work, will know that something is probably going on. But again, I would think like just them having that understanding and sensitivity not to then start probing when somebody comes back to work, because it can be a scary time definitely coming back as well, can't it? And I think just being very sensitive to the person that's coming back, and what their needs are.
Great. We might not be able to answer this one, Liam, but we can certainly come back to it. But you may know, IAPT isn't available in Wales. Is there an equivalent service? Is that one we should come back to the individual?
Yeah, I actually didn't know that, but I could look into it.
Yeah. Okay. Well, Leanna, we'll come back to you on that one, and any other people that are listening in today from outside of England, and make sure that we get the answers on that one. The next question is an interesting one here. It says, my mum is having counselling for PTSD following a health scare, near-death experience, and she's now on medication for life. She's now terrified of things like falling over, cutting herself, any pains, aches, etc. How can I support her and validate her feelings without embedding the fears long term?
I mean, I think it's really hard if she's already having the counselling for this, and hopefully she'll be able to take something away from the treatment itself. But just as again validating what it is that she's worrying about, so you could speak to your mum about it and just say that you understand that or you appreciate that that's really scary for her, but these things are in place now to keep you safe, or you've got the medication, and all you can do is be careful. Within IPT, again, it would be looking at that role transition, and you could look at some positives in like the new role, like the new kind of the changes, which I know can seem really, really difficult when something might seem that there is no positives in it, but just looking at kind of what was going on in the past, the difficulties that your mum might have been having, and then what's the difference now? Is there anything positive that's going on now? Is what will make your mum feel safe? But yeah, that sounds like a tough situation to be in.
Definitely, and I know from some of the things that we talk to people about in terms of understanding sort of negative thoughts, negative thinking within CBT, it's about understanding is kind of what you think is what you feel, and challenging, sort of in sort of quite a constructive way some of those negative thoughts, breaking down some of the catastrophizing, the alternative thoughts. We have a really good talk actually on the Mental Health UK website, which is called Taking Your Thoughts to Court, which we can send around to people. Well, but I didn't know if you had
which is like cognitive restructuring, isn't it? Taking your thoughts to court. I think a lot of the time there's lots of worry, isn't there, around health, and there's a lot of hypothetical worrying about like, what if this happens, what if that happens? But again, that is all hypothetical, and having those worries isn't going to change what's going to happen. So it's about looking at how much you'll let that kind of control your life now, and like you say, kind of challenging those unhelpful thoughts and the worrying thoughts, or and again, those self-help guides as well have tools and resources in them around like health anxiety and anxiety itself as well, which will have some information about like unhelpful thinking styles and kind of thought challenging.
Great. Just a couple more questions coming through here, and then we'll see where we're up to. But the next question is from Sarah. Sarah asks, what's the best way to get managers to engage more in understanding mental health challenges? She says that all of our senior managers state that because they've never experienced it themselves, it's not something that they get. Presumably sort of workplace mental health training is something that's quite positive for that. Is there anything else that you can think of?
Other than training, I really couldn't think, I suppose, unless people feel comfortable to share their stories with people, so that they can get, and I know people don't always understand, but they should be able to appreciate that somebody's going through a difficult time, and you know, one of the things that we really value is lived experience and talking to people about kind of their experiences of that. And I think it can be a difficult thing to do, but you want to put yourself in someone else's shoes, but leave your socks on. So you want to kind of get an understanding, appreciation of what they are feeling, but without it kind of filtering onto you. But just, I suppose, sharing with them if you feel comfortable to do that. But definitely training and just openness, I suppose.
Right. And I think, if anybody who's joining this webinar today would like to understand a little bit more about what Mental Health UK can provide in that space, I'm really happy for you to reach out to myself or to the partnerships team, and we can talk about the range of training that we have available. But also we have a suite of information on our website, which you can just download, print off and give out to your colleagues. Which actually brings me on to the next question here, which is, would you recommend anywhere to get information to hand out to colleagues, to leaflets, etc.? Presumably Rethink, and I know Mental Health UK certainly has some things that we can share with people.
Yeah, and the NHS websites have really useful tools on there as well. But Rethink, I know I use a lot of the resources from Rethink to give to service users, to clients that have information on of the different difficulties. And again, it's just that education, isn't it? But yeah, I would say like the Rethink ones. I imagine Mental Health UK have some really useful tools, and NHS websites.
Yeah, great. And then I think just the final question that I'm going to take on, well, there's a couple of questions that have asked sort of similar things. It's about sort of like the increase in prevalence in sort of workplace mental health issues. What's the sort of response time for getting support? Are we seeing generally an increase in demand and conditions within the sector, would you say?
Absolutely, yeah. I think so there was lots and lots of communications went around within like the different IAP services in the Northeast, and I imagine again across the other services as well, about like what was going to be like a big surge in referrals. A lot of services went to telephone support and kind of video support only within the pandemic, because obviously of restrictions. But there were like there was a massive increase in referrals. IAPT. So my understanding of IAPT, so the services that I've always worked in, is that kind of you'll be assessed within the first 4 weeks, and then the wait for treatment should be no longer than like 16 weeks, which I know sounds like a long time, but if you think for some kind of more intense psychological therapies that you could have, or like psychotherapies that you could have as well, you're looking at around 12 to 18 months to wait. So the 16-week mark, although can feel challenging and a long time to wait for some people, it is relatively short, but you would be assessed before that, and they can offer you information to support you in the interim. And again, there's all the resources online that you can access to, and there's also like so obviously you can access telephone support, kind of Zoom, Teams, that kind of thing, but they do online CBT as well. So I know some services that people don't always want to speak to somebody about it, so they've got like online courses that you can do where one of the clinicians will log in to talk to you on the chat and guide you through the materials online. And then you can kind of do it in your own time as well, so that you don't feel like you need to be at appointments, because obviously lots of people lead very busy lives, don't they? So it can be hard to fit it in. Yeah.
Okay. Listen, thank you so much for chatting with us today, Liam. I think just
no problem.
Talk about the next webinar that we've got coming up. I mean, there were a couple of things that were really useful for me out of this, and firstly is that a negative life experience can be completely different for one person to another. So it's really important when you're going into that conversation to be open-minded and to very much be in listening mode, as you've talked about today. I think a couple of other things that we've picked up on is the fact that sometimes a diagnosis can be unhelpful, and that it's more important to be focusing on the issue in hand and how you can support that person rather than chasing a label, which sadly sometimes can still be stigmatizing. You mentioned employee assistance programs. I've seen them referenced throughout the chat here. They are cost effective and can bring about great results, but also we have an amazing NHS system. Our GPs are there, IAPT is there, they're open and accessible to everybody. And for anybody who is looking looking for more, there's a question about statistics around mental health, Darren, we can send you some signposting information to where you can find information on that to make the evidence base to your managers, and lots of things that we'll send through following on from this session today. So thank you again, Liam, for taking part. Really interestingly, through the thread today, there's been quite a few references to sort of financial worries and issues when it relates to an individual's mental health, which makes me feel really pleased to announce the subject of our next webinar, which will be on Thursday, the 15th of July at 10 a.m, where we'll be talking about how to support colleagues with money problems. And I'll be interviewing my colleague, Sarah Murphy, who is our Associate Director of Advice, Information and Training at Mental Health UK, and she heads up our incredible award-winning mental health and money advice service, which we've been running now for the past couple of years. So I look forward to seeing as many of you as are available to make it on Thursday the 15th of July, and we'll send out details as to how to register for that again in the email that we put out just a bit later on today. So it leaves me nothing more to say than, again, thank you to you, Liam. This has been a fantastic session, and I hope we can invite you back again at some point in the future.
Yeah, definitely. Thank you very much.
Absolute pleasure, absolute pleasure. Well, thank you ever so much, everybody, and we'll see you again in about a month's time. Take care.
Thanks, bye.